All right, guys, so this is going to be upper extremity blocks number 2. So we're going to cover axillary block, distal extremity blocks, and also IV regional anesthesia. So per usual, here are your objectives to help guide your studies for the exam. I definitely would key in on all of these and also review your APEX modules. So starting off, we're going to cover the axillary nerve block. So primarily, your axillary nerve blocks are going to be for procedures at or below the elbow. One of the primary risks of an axillary block is its risk of blast. Historically, we used a transarterial technique before the use of ultrasound. So this was definitely something that we had to consider. Also, we have a separate injection or redirection of the needle that is needed to cover the musculocutaneous nerve. If we look here at the distribution of anesthesia, you can see it covers from the mid-arm down to the hand. Okay, it does not anesthetize the skin over the deltoid. It does not actually cover the axillary nerve, and then the musculocutaneous, like we said, is unreliably blocked with, so we want to use a nerve stimulator and landmark techniques, okay? So the axillary nerve block is formed usually at the lateral border of the pectoralis minor muscle. The cords of the brachial plexus then form our large terminal branches. Okay, and the axillary, musculocutaneous, and medial brachiocutaneous nerves branch from the brachial plexus proximal to where the local anesthetic is deposited, and thus they are spared. So the goal for an axillary block is to have local anesthetic spread around the axillary artery. However, there can be some very pronounced anatomical variations in this area. So pro tip, identify the biceps or choriobrachialis with the sandwich musculocutaneous to best orient and identify the median, ulnar, and radial nerves. Remembering, MC for musculocutaneous is closest to the median nerve. Okay, here's a little breakdown of what we have. Okay, so we can see that here's the brachial deep fascia. 2 is your median nerve. 3, we have the axillary vein. 4, ulnar nerve. 5, radial nerve. 6 is here is your musculocutaneous nerve, okay? And that's what I was saying, the biceps brachialis and the coracobrachialis muscle there, and the sandwich right in between. And, of course, we have the axillary artery as well. All right. And these are just some anatomic variations that you can see of this. Now, that's why it is important to understand these anatomy variations. That way we can identify the nerves appropriately. But most importantly, you want to remember the orientation stays the same, right? 6, 2, 4, 5, 6, 2, 4, 5, 6, 2, 4, 5, 6, 2, 4, 5. So if you remember in a clockwise motion, depending on which side you're looking at, you're going to be able to remember the nerves and that orientation. Okay. There's also external landmarks that we can look at for an axillary block. So the axillary artery, obviously, at the lateral margin of the pectoralis major muscle, high up in the axilla. So you're going to have the patient in a supine position. The arm that is going to be blocked is abducted 90 degrees from the body, and the forearm is flexed to 90 degrees and rested parallel to the long axis of the body. Now, this may not be possible with all of your patients, just depending on their range of motion and their ability to move. So we have optimal positioning for this, and we try to get as close to that as possible. So we have some different things that we need to review here just to ensure that we don't forget them. So nerves are going to be often difficult to distinguish from surrounding tissue in ultrasound images, okay? In general, nerves are going to appear as bright structures with black spots inside, okay? The normal nerve displays in an uninterrupted vesicular or filamentous pattern, unlike the intercalculated pattern of a typical tendon, all right? Nerve fascicles are not as tightly packed as the fibers in a tendon, and the nerves have an epineurium, okay, which is the external sheath that surrounds the nerve fascicles. The epineurium is seen as a bright signal on ultrasound, and the nerve fascicles are dark, all right? The nerve fascicles are enveloped by that perineurium, and the individual fibers are enveloped by the endoneurium. The tissue between the fascicles and the outer sheath is sometimes referred to as the inner epineurium, okay? and the external sheath is referred to as the outer epineurium. So as we said, the fascicles are enveloped by the perineurium, and the individual fibers are enveloped by the endoneurium. All right, the tissue between the fascicles and the outer sheath, sometimes, like we said, is referred to the inner epineurium, and the outer external sheath is referred to as the outer epineurium. So this is, you can see a short axis of the proximal median nerve right here. So we can see the perineurium, okay, and then endoneurium, and then here's all of our different fascicles. So peripheral nerves have an extensive vascular supply to provide for their metabolic needs. All right, large peripheral nerves are often accompanied by arteries and veins that are easily recognized with ultrasound. Nerves also have a network of vessels that travel longitudinally in their epineurium with the branches that enter as endoneural vessels among the fascicles. And you can see that in the illustration here to the right. So peripheral nerves generally display a characteristic appearance with high-frequency ultrasonography and short-axis view. Okay. Nerves display a honeycomb appearance with hypoechoic fascicles laying inside a more hyperechoic background. In long-axis view, peripheral nerves display a characteristic fascicular pattern within multiple longitudinal hypoechoic bands of fascicular bundles. All right, the hyperechoic bands are intervening epineurium. The size and number of fascicles seen in nerves can be highly variable depending on the nerve size and the location in the body. So the short axis view of the nerve is generally the best image to differentiate it from surrounding tissue. It also assists in understanding the relationship to adjacent structures. Longitudinal views also provide valuable information, but are more difficult to obtain as they frequently curve out of field of view. Okay. All right, so here's the sciatic nerve in short axis, and you can see that classic honeycomb structure. Sciatic nerve is one of the largest nerves in your body. Here's the sciatic nerve in long axis. All right, so remember, the imaging characteristic of abnormal nerve is often related to the nature of the injury. Okay, so focal nerve entrapments typically present with swelling proximal to the entrapment site with notching at the level of compression. Okay, there's often a loss of the fascicular architecture in long axis and destruction of the characteristic honeycomb pattern in short axis view with substantial injury. When we have tension neuropathy, the imaging abnormalities can be relatively inconspicuous. There is a multitude of theories regarding the cause of nerve swelling and focal neuropathy, but this includes the blocking of the axoplasmic flow, endoneural edema, distal axonal degeneration, perineural and endoneural inflammation, perineural fibrosis, axon sprouting, remyelination, and thickening of the perineurium and epineurium. Here's what focal nerve entrapment with swelling proximal to the compression sites and notching. The yellow arrows was what the entrapment site is indicating. So this is similar to what carpal tunnel, what happens with carpal tunnel. Here we can see the disruption in the fascicular architecture of the peripheral nerve in short axis view. Okay. This illustration is showing that normal fascicular pattern here in part A. And then in part B, the fascicles are enlarged and irregular, denoting that neuropathy. Okay, sonogram shows those enlarged fascicles as well. Okay, so the relative echogenicity of the nerve structure tends to decrease in pathologic states. Okay, this parameter is difficult to quantify precisely, but the use of proximal and distal scanning as well as side-to-side comparisons can help with assessment. So a contributing factor to this is when decreased contrast with the surrounding muscle is denervated or in conditions such as myopathy. Okay, the diseased muscle echotexture becomes more isoechoic with that of the peripheral nerves, resulting in less contrast. And here's a good illustration of how we can see a difference in echogenicity in a pathologic state. That image on the left is of an abnormal fibular nerve, represented by the yellow arrow here. It appears hypoechoic relative to the normal fibular nerve. On the red arrow at the right, you can see So a nice hyperechoic signal that we're getting, and here, hypoechoic. Okay. So here's some different illustrations of what potential nerves that displays conduction blocks or issues with conduction. So we can see in illustration A, it appears to have focal swelling but relatively normal fascicular architecture. In B, the nerve does not appear to be swollen, but there's dramatic enlarged fascicles. In C, it would be considered a normal anatomy. All right, back to our axillary nerve block, okay? So remember our orientation here, right? Musculocutaneous, median nerve, ulnar nerve, radial nerve, okay? Remember your musculocutaneous is the one that you have to provide a separate injection for, okay? So we're looking at axillary ultrasound anatomy. This is a really good image for you to use in the lab when we're scanning, just to compare it to what you're actually seeing. And then side by side, you can see the listed anatomy there on the left, okay, and what it actually looks like on a cadaver. All right, here's a good illustration or picture that shows us kind of the technique here. You can see your needle path and your probe placement, okay? All right, so here we can see our typical needle path and where we're going to inject. So they're showing 3 different redirections here. So first we're going to come down through here and get the musculocutaneous nerve, redirect, come just on the underside of the axillary artery, inject on that posterior side, and then back up for our most superficial injection here on the top of the axillary artery. Okay. And this would give you good, reliable coverage of all these terminal branches. Okay. Here's another good ultrasound image showing a little bit different orientation here. Okay. Again, what we're seeing here is a little feeder artery in the tissue that we want to be sure that we're not getting into. Also, you can really see how the biceps and corpobrachialis are really sandwiching that musculocutaneous nerve there. All right. So to perform an ultrasound-guided axillary nerve block, the skin is going to be disinfected and the transducer is positioned in the short axis orientation to identify the axillary artery. It's usually going to be 1 to 3 centimeters from the skin surface. Once we identify the artery, the attempt is going to be made to identify the hyperechoic median, ulnar, and radial nerves. Okay, these may not always be well visualized with ultrasound. And then frequently present is an acoustic enhancement artifact deep to the artery is often misinterpreted as the radial nerve. Okay, remember that ultrasound beams, they flow through that blood really easy, leading to an acoustic enhancement on the opposite side of that artery. So usually what we want to do is pre-scan, so we want to reveal the position of the musculocutaneous nerve in the plane between the corpobrachialis and biceps muscles, or within either of the muscles, depending on where we intersect it. Okay, a slight proximal to distal movement of the transducer is often required to bring this nerve into view. Okay. Then the needle is going to be inserted using an in-plane technique from the anterior aspect and directed towards the posterior aspect of the axillary artery. All right, because those nerves and vessels are positioned closely together in the neurovascular bundle by adjacent musculature, the advancement of the needle may require careful hydrodissection with a small amount of local anesthetic or other injectates. Okay. Usually we're going to inject 1/2 to 2 mLs to help indicate what plane the needle tip is located in, and then the needle is then carefully advanced stepwise a few millimeters at a time. Okay. The use of nerve stimulation is recommended to decrease the risk of needle nerve injury during needle advancement. Then local anesthetic should be deposited posterior to the artery first to avoid displacing the structures of interest deeper and obscuring the nerves, which may occur if injections for the median or ulnar nerves are carried out first. Remember, we always go deep to superficial with our injections, as we've always learned. Okay, so here's your your 2 different injections here. So the posteriorly located radial nerve is often visualized more clearly once surrounded by local anesthetic. But once 5 to 7 mLs has been administered, the needle is withdrawn almost to the level of the skin and redirected towards the median ulnar and ulnar nerves, and further 7 to 10 mLs is injected in these areas to complete the spread around the nerves. So you can see the blue area in this slide. That's where you want to see your local anesthetic. Okay. We also have the perivascular approach, which is simply to inject local anesthetic deep to the artery at the 6 o'clock position instead of targeting the 3 nerves individually. Okay. This may shorten the duration of the block procedure, but it also can delay the onset time, resulting in no difference in total time from skin puncture to the onset of surgical block. Okay. The last step in the procedure is the needle is drawn and redirected toward the musculocutaneous nerve. Once adjacent to the nerve, stimulation will result in elbow flexion, and we're going to deposit 5 to 7 mLs of local anesthetic. Okay. Occasionally, that musculocutaneous will lie close in proximity to the median nerve, rendering a separate injection unnecessary. Okay. All right. Usually, about 20 mLs of local anesthetic for these patients is going to be sufficient. An adequate spread within the axillary brachial plexus sheath is necessary for success, but infrequently seen with a single injection. This is usually accomplished with 2 to 3 redirections, and injections of 5 to 7 mLs are necessary for a reliable block, as well as a separate injection to the musculocutaneous nerve, as we discussed. So if you're going to leave a catheter for continuous ultrasound-guided axillary block, the goal is to place the catheter within the vicinity of the branches of the brachial plexus, okay, ideally within the sheath that we've been discussing. The needle is typically inserted, like we said, in plain anterior to posterior direction, and just as then we do it as a single injection. And after an injection of the local anesthetic to confirm proper needle tip position, the catheter is then inserted 3 to 5 centimeters beyond the needle tip. Injection is then repeated through the catheter to document adequate spread of local anesthetic, wrapping the axillary artery. Alternatively, axillary artery can be visualized in the longitudinal view with the catheter being inserted in the longitudinal plane alongside the axillary artery. This requires significantly greater degree of ultrasonographic skill, but there's no data suggesting that one approach is more effective than any of the others. So for axillary block, remember, frequent aspiration and slow administration of local anesthetic are going to be critical for decreasing the risk of intravascular injection. And in cases of systemic toxicity have been reported after apparently straightforward ultrasound-guided axillary brachial plexus block. So be very, very cautious with these. So if no spread is seen on the ultrasound image, despite local anesthetic injection, the tip of the needle may be located in a vein. If this occurs, injection should be halted immediately and the needle should be withdrawn slightly. Okay. Pressure on the transducer should be eased before reassessing the ultrasound image for the presence of vascular structures. Remember, we can compress those venous structures and make them a little bit harder to see. Remember, we have the anatomic variations in the position of the musculocutaneous nerve, as we discussed, and in 16% of cases, the musculocutaneous nerve splits off the median nerve distally to the axilla. In this case, a separate injection is not going to be needed for the block to block that musculocutaneous nerve. It will be blocked by the local anesthetic around the median nerve. And then, as I said, we have the transarterial technique, which is intentional penetration of the axillary artery, and the aspiration of blood is an endpoint for determining the needle is within the sheath. Okay, after artery identification, you localize the skin, and a 22 gauge needle is inserted perpendicular to the skin with extension tubing and a syringe that is then used to identify arterial puncture via continuous aspiration. Needles advance until blood return ceases to flow, and then a test dose is administered under careful observation of the patient. Upon removal of the needle, a field block is performed to ensure coverage of the musculocutaneous nerve. Then injection is technique and source dependent. So ultrasound, you can inject around 15 to 20 mLs of local in small increments. Usually for the landmark technique, higher volumes is going to be required. So greater than 20, sometimes all the way up to 40 mLs. All right, so let's talk a little bit about what an actual local infiltration block is. So it's focusing on the terminal cutaneous nerves. It's commonly used by surgeons to minimize incisional pain and may supplement the primary anesthesia technique or be used as a sole anesthetic for minor superficial procedures, such as an incisional hernia repair versus a carpal tunnel. Obviously, for an incisional hernia repair, we cannot completely provide an anesthetic with a local infiltration, but with the carpal tunnel, they can localize and perform that surgery just with local. So a field block is a technique that targets, like we said, those terminal cutaneous nerves. You can also hear it called be called local injection, or local infiltration. All right. So a field block, as we said, is going to be a type of regional anesthesia where local anesthetic is injected in a ring-like fashion around the surgical site to block afferent nerve fibers before they reach the area of injury or incision. And then with local infiltration, it's a technique where local anesthetic is injected directly into the tissue at the site of procedure to numb the immediate area. Okay, so a field block provides regional anesthesia by blocking through nerve fibers before they reach the surgical site, whereas local infiltration works at the site of the procedure, numbing the tissue directly where it's injected. Usually field blocks are going to be more effective for procedures where diffuse nerve input is expected, while local is best for superficial or localized procedures. So we use these in minor surgical procedures, obstetric anesthesia, and some dental or dermatologic interventions. It would significantly reduce our need for systemic opioids and general anesthesia in certain cases. But we have to understand the diffusion, duration, and systemic absorption of local anesthetics when we're selecting these for the best approach. All right. Remember some of our pharmacokinetic considerations for our different drugs. We have lidocaine, which is fast onset, short duration. It's great for peripheral IVs, really short procedures. Bupivacaine has a slower onset, but a better prolonged duration. But remember, it's cardiotoxic. Ropivacaine has an intermediate onset and reduced cardiotoxicity. All right, so as far as systemic absorption goes, there's higher risk with field blocks due to the larger volume usage and vascular uptake. It is lower with local infiltration, but repeated dosing increases the risk of systemic toxicity, as you would imagine. With local infiltration, there's usually a rapid injection in highly vascular areas can cause blast, whereas with the field block, the higher volume use means monitoring for delayed systemic absorption is necessary. So if we're injecting a large amount in one single area, sometimes that large amount can be absorbed and cause blast. So remember, all of our dosing is adjusted based on patient weight, site vascularity, and total anesthetic volume. We obviously want to avoid IV injection by aspirating before injection. And we want to consider the addition of epinephrine to prolong duration and reduce systemic absorption. So remember, with the field block, we can use those with hernia repair, breast surgery, scalp procedures, extremity surgeries. Local infiltration, you'll see with skin biopsies, suturing, dental anesthesia, and superficial excisions. All right. Remember, field blocks require precise anatomical knowledge to avoid missing key nerves. Infiltration may be inadequate for deeper structures or larger surgical sites. And we should assess the patient's comorbidities like cardiac history, anticoagulation status before choosing our different techniques. So remember, when we're choosing our local anesthetic, we have to choose the right one, okay, for the length of the procedure. And also we have to pay attention to our maximum dose. All right, always aspirate when we're using any sort of IV. To prevent IV administration, we're going to consider adjuncts to help prolong our duration and reduce systemic absorption. You can also add some sodium bicarbonate to reduce our injection pain. And as always, we're going to monitor for complications and know where our intralipids are in case of blast. And we can also use ultrasound guidance for deeper field blocks. But as we all have probably seen clinically, these field blocks help minimize opioid needs. They're going to reduce our general anesthetic requirements. And they're also going to enhance our multimode pain management strategies. All right, let's talk a little bit about distal nerve blocks, the forearm, wrist, and some digital nerve blocks. So we know that with our field block and local infiltration, it's going to provide a broader pain relief. It's going to last longer if the nerves are properly blocked. There is a little bit higher dose of local anesthetic or volume required most of the time. There is an increased risk of vascular uptake, and it does require some knowledge of anatomy. So when we're talking about distal nerve blocks, they're going to be essential for anesthesia and analgesia in hand, wrist, and forearm surgeries. Okay, that provides effective pain control while preserving proximal limb function. Okay, blocks include the forearm, wrist, and digital nerve blocks. Each have specific indications and techniques. We're going to use these blocks to enhance analgesia, facilitate same-day surgery discharge, and minimize general anesthesia complications. We're talking about forearm nerve blocks, okay? We're going to target the individual nerves at the mid-forearm level. It's going to be ideal for procedures involving the hand and wrist, preserving proximal motor function. So we're targeting primarily the median, ulnar, and radial nerves. We can use landmark-based or ultrasound-guided approaches. So the median nerve runs between the flexor digitorum superficialis, or the FDS, and the flexor digitorum profundus, FDP, at the mid-forearm level. Okay, indications are for anesthesia of the volar aspect of the thumb, index, and middle fingers, and lateral ring finger. Okay, we're usually going to inject 3 to 5 centimeters proximal to the wrist crease, medial to the flexor carpi radialis tendon. Ultrasound guidance enhances the accuracy and reduces complications with this block. When we're imaging the median nerve at the elbow crease, the median nerve is located superficially at the elbow, at the level of the elbow crease. Okay, the transducer is placed just above the crease and adjusted to visualize the brachial artery. The median nerve appears as a hyperechoic and oval-shaped position medially to the brachial artery and of similar size. Okay. Proximally, the median nerve and brachial artery course together towards the axilla. Usually that's the position. They can change. And then distally, the median nerve separates from the artery lying deep to the pronator teres and flexor digitorum superficialis in the mid forearm. All right, so here's your brachial artery right here, and musculocutaneous nerve there medial. And here would be your in-plane technique to help block that median nerve. Ulnar nerve is located medial to the ulnar artery at the forearm. It enters the Goyen's canal at the wrist. We're going to use this for sensory blockade of the medial half of the ring finger and the entire small finger. Okay, we're going to palpate the ulnar artery and inject just medial to it at the wrist or between the flexor carpi ulnaris and the FDP in the forearm. Okay, we want to be very careful to avoid intravascular injection. And as always, ultrasound improves our accuracy. So when we're imaging the ulnar nerve, it is identified as the posterior medial aspect of the elbow, okay, a few centimeters proximal to the crease. Okay, it appears as a hyperechoic oval honeycomb structure located beneath the brachial fascia and superficial to the triceps muscle. We'll see that coming up here in the image. Distally, the ulnar nerve courses towards the ulnar notch, becoming a round hypoechoic structure as it dives into the bony ulnar sulcus before passing under the flexor carpi ulnaris muscle in the forearm. Okay. Proximally, the nerve can be traced back to the axilla running along the medial aspect of the arm. Okay, here we go. So now we've got our ulnar nerve. Okay, and we can see right here. Remember, this is at the same level that we were imaging that brachial or the median nerve at. All right, you can see they really got that arm externally rotated. They're coming in from the anterior side, blocking that ulnar nerve right here. For the radial nerve, it's a superficial branch that crosses the distal radius, providing sensory innervation to the dorsum of the hand. All right, so indications are dorsal anesthesia for hand procedures, thumb surgery. We're going to inject subcutaneously over the distal radius at the wrist level or along the lateral forearm. All right, A field block technique is often used for complete dorsal coverage. When we're imaging the radial nerve, it's best visualized above the lateral aspect of the elbow, positioned in the interfascial plane between the brachioradialis and the brachialis muscles. Okay, the transducer is placed transversely along the anterior lateral aspect of the distal arm, 3 to 4 centimeters above the elbow crease, and the nerve appears as that hyperechoic with a triangular or oval shape and a honeycomb pattern characteristic of the distal peripheral nerves. So here's a good image of this. So brachioradialis, brachialis, and your radial nerve. And remember, this is anterior here, okay? All right. There's another view of the radial nerve. All right. So now you can see how they're coming in here on the anterior side and where they have that probe positioned. For a wrist block, we're targeting the radial, median, and ulnar nerves at the wrist level. It's indicated for minor hand and finger surgeries. We're going to preserve the elbow and forearm motor function, which is ideal for outpatient surgery. It does require multiple injections for complete coverage. Okay, you can see here ultrasonic guided wrist nerve block and the different positions that we're going to put the transducer and needles in. All right, so here is your ulna, ulnar artery, and ulnar nerve. Okay, we're looking at the radial nerve. We have the radius, the radial artery, and the radial nerve just on the lateral side of that radial artery. We're doing a digital nerve block, okay? These work extremely well for procedures on the individual fingers. It does block the dorsal and volar digital nerves. It avoids excessive anesthesia and limiting unnecessary motor involvement. Ideal for fractures, laceration repairs, and nail bed injuries. I've seen a lot of, like partial amputations that are being revised. You can do a nice digital block and an isolated nerve block for the finger. And patients, I've done them with a patient literally awake. So you can see here, here's the digital nerve that serves on each side of the finger, and I'll just inject on both sides there, like so. All right. So we're going to inject at the base of the digit on both the dorsal and volar aspects. We use small volumes, 1 to 2 mLs per site, to avoid compartment syndrome. We want to be very careful to not use epinephrine or use very small amounts to prevent vascular compromise. Okay. Patient will experience pain if it's injected into the nerve, and then there is an infection risk with poor aseptic technique. All right, we can use ultrasound for these distal nerve blocks. That helps enhance our accuracy and reduce complications. All right, it identifies the nerves and adjacent vascular structures. And we're going to reduce the required anesthetic volume, minimizing our risk for systemic toxicity, okay, these are recommended for forearm and wrist blocks, and I've not seen them used for digital blocks, okay. Here's some different complications of digital blocks that I suggest you review. Again, complications of digital blocks. All right, now let's cover some beer blocks, or IV regional anesthesia. All right. So the mechanism of action is the entire extremity distal to the level of tourniquet is going to be anesthetized. There's going to be 2 mechanisms of anesthesia. We have peripheral infiltration block, which is direct anesthesia, which is local anesthetic bathing bare nerve endings in the tissue, and then a conduction block through indirect anesthesia, where the local anesthetic being transported to the substance of the nerves via the vasa nivorium. Okay, the block duration is determined by the duration of the inflation of the tourniquet, which is i.e. the length of occlusion of the blood vessels. There is rapid recovery following tourniquet deflation as the blood dilutes the local anesthetic concentration. right, here's some indications and contraindications to review. All right, so it's a regional anesthesia, as we said, technique where local anesthetic is injected into the venous system of an isolated limb to achieve temporary anesthesia and analgesia. It's first described by August Beer in 1908, and it was commonly used for short upper extremity procedures. The key advantage is it provides rapid onset, reliable anesthesia, and muscle relaxation with minimal systemic effects. We use these still for hand, wrist, and forearm surgeries lasting less than 60 minutes. The venous system extremities allows distribution of that local anesthetic within the limb. The tourniquet application is what isolates the circulatory system, preventing systemic absorption. And the local anesthetic diffuses from the venous system to the surrounding nerves. Like we said, they have that really dependent blood flow, leading to a sensory blockade, motor blockade, and sympathetic blockade. As we covered earlier, indicated for upper extremity procedures in the hand, wrist, and forearm with a short surgical duration, less than 60 minutes. And this is great for patients that are unable to tolerate general anesthesia. Some contraindications, you can also review those that were on that chart, but severe peripheral vascular disease, Raynaud's disease or other vascular compromise, sickle cell disease, severe uncontrolled hypertension, allergy to local anesthetics, and inability to tolerate the tourniquet pain. So how are we going to do this? We're going to establish IV access in the operative limb. Okay? We're going to apply all of our normal monitors and ensure that we have resuscitation equipment available. We're going to elevate the limb for 1 to 2 minutes to help promote venous drainage. We're going to apply an S-mark bandage from distal to proximal to exsanguinate the limb. And we're going to inflate the proximal tourniquet to 250 to 300 millimeters of mercury or 100 millimeters of mercury above systolic blood pressure. We're then going to inject local anesthetic via IV catheter in the isolated limb. Monitor for signs of a successful block, numbness, paralysis, loss of cold sensation, all the things we normally look at. And wait at least 20 to 25 minutes before deflating the tourniquet to prevent systemic toxicity. And we're going to deflate the tourniquet gradually, which allows for that local anesthetic to slowly seep out. Then we're going to assess the patient for systemic toxicity before discharge. So remember, you have to have an IV in the operative arm. You can see they're raising up the arm there, putting the S mark on, and then inflating the tourniquet. And a lot of times we'll give a little bit of propofol just to provide some anxiolysis and sedation with the initial tourniquet inflation. Okay, so lidocaine, 0.5% is going to be the most commonly used for this. Remember our dose, 3 milligrams per kilo with a max of 300 milligrams. Onset's going to be less than 5 minutes, duration of 30 to 60 minutes. We don't use any epinephrine due to the risk of ischemia. You can also use prolicaine, 0.5%. It does have a lower risk of toxicity. Dose is anywhere from 3 to 6 milligrams per kilo for your max dose. And it's metabolized a lot faster than lidocaine, leading to the lower risk of toxicity. We also can use mepivacaine, 1.5%. So generally it comes in 450 milligrams in a 30 ml vial. In an adult, use 20 to 30 mLs plus 10 mLs of normal saline for volume and additives. It's safe up to 7 milligrams per kilo. We're going to avoid bupivacaine due to the risk of cardiotoxicity if it's systemically absorbed. All right. So tourniquet pain and management, I'm not sure if any of you guys have ever had a patient that has a tourniquet on under general anesthesia, and about that 60-minute mark, they start to really show some signs of sympathetic activation because of that tourniquet pain. It's pretty serious. So this also happens with the beer block. It occurs usually 20 to 30 minutes after inflation due to that ischemia. Common symptoms are burning pain, discomfort, anxiety, hypertension. So how can we manage that? We're going to inflate a distal cuff if we have a double tourniquet used, deflate the proximal cuff, administer some low-dose sedation, Versed, fentanyl, and consider regional or general anesthesia if there is prolonged discomfort and say we're getting towards the end of that beer block anyway. What are some complications of IV regional anesthesia? Tourniquet pain, like we just discussed, managed with distal cuff inflation and sedation. Local anesthetic systemic toxicity, this goes without saying, but it occurs if the tourniquet fails or is released too early. Remember our early signs and severe signs, okay? And management, what are we going to do? We're going to stop injection, administer our intralipid 20%, a bolus of 1.5 mL per kilo, and then a continued infusion of 0.25 mL per kilo per minute. Compartment syndrome, it's rare, but we're going to suspect of severe pain post-tourniquet deflation. Nerve injury, we're going to avoid excessive tourniquet pressure for prolonged inflation times. So deflation techniques and post-procedure care. This is probably the most important thing for a beer block. We're going to wait at least 20 minutes before deflation to minimize systemic absorption. All right. We're going to use sequential deflation, reinflation. So we're going to deflate for 5 seconds, reinflate for 1 minute. Repeat that for 2 to 3 cycles. If we do a single full deflation, make sure you're monitoring very closely for last symptoms. And then post-block care, assess motor and sensory recovery, monitor for delayed systemic toxicity, and ensure full tourniquet recovery before patient discharge. Again, here's another nice review. And that is it, guys. As usual, if you have any questions, just shout out and let me know if I can help in any way.